We'll move on to the next speaker, who is Professor Zhang. Professor Zhang is an Associate Chief Physician, Associate Professor, Master Supervisor at the Ultrasound Diagnosis Department at the Second Affiliated Hospital, 4th Military Medical University of the Air Force Military Medical University. Professor Zhang is a member of the Standing Committee of the National Ultrasonic Reproductive Health and Pregnancy Rehabilitation Medical Conference, a member of the Standing Committee of Ultrasonic Molecular Imaging, Professional Committee of the Engineering Society of Ultrasonic Medical Association of China. And the topic is HICOSI. Please.
Dear Chairman, hello everyone. Today I'd like to introduce some of our work about fallopian tube patency assessed by 4D HICOSI. I'm Zhang from the Air Force Medical University, Chengdu Hospital. As we know, tuber problems take the second place responsible for the female infertility, so the assessment of tuber patency is very important for clinical management. Many reasons can cause tuber blockage, such as tuber inflammation, pelvic adhesion, and etc. Nowadays in China, we mainly have three methods for tuber patency assessment: X-ray hysterosalpingography, which is also called HSG, laparoscopic examination, which is considered as the reference standard, and HICOSI. The very important tips for patients' preparation is the examination time. It should be 3 to 7 days after menstruation. The timing is compulsive to make sure the endometrium can be repaired completely, and then a saccular duct was placed in the uterine cavity and then injected with 2 ml normal saline to block the intercervical mouth. The content in one Sonovil vial was first suspended with 5 ml of normal saline and then followed by further dilution of 1.5 ml up to 20 ml. Transvaginal examination was then applied to take a routine examination of the uterus and ovary, including the position of them and the relationship between them. The sliding sign by using the probe and our hands to push the cervix and the uterine fundus to test the mobility of them. And then we have to observe the sacculus. First of all, we have to observe the size of the sacculus. If it is too big, it will cause great pain for the patient and block the uterine hole, causing a tuber blockage artificially. If it is too small, the contrast agent will flow back and the sacculus will drop off. Another big issue is about the position of the sacculus. Sometimes we can find the sacculus was in the cervical canals. It is because the uterine body is too antiflexed or retroflexed. If we found that the sacculus was incarcerated in the unhealed cesarean scar, it has the potential risk to causing uterine rupture if we ignore them. And then 5 ml normal saline was injected into the cavity to check whether there is any lesions in the cavity. For this patient, there are several polyps in the cavity, and for this patient below, we can see adhesion here. Another aim for this process is to make a prognosis of the tuber patency by feeling the injection resistance and determine the injection speed. And then a 4D imaging was initiated to make sure we can cover both the uterine hole and the bilateral ovary in order to make sure we can include the entire tube between 4D scanning. After all this preparation work, 4D function was started and we can start the hycosis. We divided this phase into 3 phases. The first one is intrauterine imaging phase. Second is fallopian tube imaging phase. And then the pelvic imaging phase. In each phase, we have different content to be observed. During the 4D process, we have to focus on any details. We can get direct information from what we have observed during 3 phases. And besides that, we can also get many indirect information from the assistants, including the injection resistance, how much contrast agent was injected into the cavity, and how much reflex, and also the extent of pain the patient feels. After hycosis, we have to double check the uterine cavity after the sacculus is released, and for a 3D image of the uterus to check whether there is any uterine abnormal. For a pattern tube, when the contrast agent was injected into the uterine cavity take a look as an inverted triangle, and following the contrast flowing inside rapidly, both tubes appeared almost at the same time and extended naturally. At the end of the tube, we can see contrast agent spreading from the end and diffused extensively in the pelvic cavity. And the uterus and both the ovaries were surrounded roundly by the contrast agent. And all the 20 milliliter contrast agent can be injected with little or no resistance, no reflex, no intravasation, and the patient doesn't feel pain. We can also use 2D hycosis to assess the tuber patency. From the horn of the uterus, we can trace the entire tube until we saw the ovary here. For a blocked tube, we cannot see the entire passage of the tube, but it depends on the site of the blockage. For this patient, the right side, the tube cannot be detected, although we can see a very good image on the right side. And because of the blockage on the left side, so there is no contrast agent spread, which leads to uneven diffusion of the contrast agent in the pelvic. Because there is no contrast agent spreading at the end of the tube, the ovary cannot be surrounded by the contrast agent. And the assistant feel the great injection resistance, and the patient feel great pain. But for this patient, we can see here, although the right tube is imaging, but at the end of the tube, there is no contrast agent spreading out. So the ovary, around the ovary, the right side ovary, there is no contrast agent surrounding the ovary. So because there is no spreading of the contrast here, so leading to a limited diffusion in the pelvic cavity. So finally, we only injected 8 milliliter contrast agent into the cavity, and during this process, the assistant felt great pain, felt great pressure, and the patient felt great pain. But for this tube, we can see here, for the right side, we can see the tube here. But the contrast flowed very slowly and laborious. At the end of its very small amount of contrast agent spreading to the pelvic cavity, and only spotted contrast agent surrounded the ovary. The assistance field also felt the great pressure during injection, and the patient felt great pain, but not that much. For this situation, we said that the right tube is patent, but it's blocked partially. During hycosis, we can detect many morphology of the tube, such as stiff and shortened, curved, directed weirdly, and angled curators. This examination is about hydrosalpinx. We can see the dilated tube segmentally or entirely. Sometimes a small amount of contrast agent flow out from the end of the tube and surrounded the ovary. And 2D conventional ultrasound examination can verify there is salpinx presented. Venous intravasation is annoying, but sometimes unavoidable. We can see here, for these two patients, along with the uterine cavity, there is the contrast agent arise from the cavity with an irregular shape. And after we retoting the X, Y, or Z axial plane, the spreading is ill-defined with the contrast with the uterine cavity here. So the intravasation is very annoying because it caused the difficulty in diagnosis. But it has clinical meanings. First of all, we have to preclude whether it's artificial error, the sacculus is too big, or the injection speed is too fast. So, secondly, is it because the incomplete repair of the endometrium? And besides that, if the intravenous intravasation take place, it is strongly suggestion for the blockage fallopian tube. For the patient with Mullerian duct abnormal, it's difficult to get a very good image of the hycosis. For this patient is very lucky because the sacculus was placed right on the bifurcation of the two cavities here. So we can take a very good image of the two cavity and the two tubes on both sides. And this patient, the tube is patent. And for the unicornus uterus, the image is very typical. For this patient, we can see a bunch of contrast agent presently initially. Here, it is a very small uterine cavity, and almost at the same time, there is a tuber-like structure arise from the left side of the uterine cavity, and at the end of the tube, there is a lot of contrast agent spreading into the cavity. After hycosis, we take a 3D image of the uterus. It is confirmed it was a unicornus uterus. And after all the examination, we take a check for other organs of the patient. We found that the patient lack of right kidney, a right fallopian tube, and a right ovary. So they only detect fallopian tube towards the left side. In 2016, we compared hycosis with HSG in 38 patients. The results showed most of the cases the diagnosis was constantly, except for 8 cases. So for the first case, here, both the hycosis and SHG, the diagnosis is unblocked tube on the left side, partially blocked tube on the right side. So the result matched with each other. And then for this patient, the hycosis showed the bilateral tubes were patterned, but HSG showed that the right tube was patterned, while the left tube was partially blocked. But whose diagnosis we should believe? When we checked the image, we found that there is the contrast agent flow back to the vaginal on SHG. So we have to see whether to trust the diagnosis of hycosis. Compared with the laparoscopic examination, we get more confidence. So for this patient, the laparoscopic examination showed there was no dye fluid flow out from the fibril. Both tubes were blocked from the intramural portion. The same result as hycosis did. And for this patient is about the hydrosalpinx. We can see here the dilated tube here, as the hycosis showed the dilated on the left side, and then so nowadays we have a lot of patients to perform hycosis in our hospital. More than 1,000 patients per year in our hospital. The patient take hycosis to assess the tuber patency. So we think hycosis is a reliable imaging method to assess the fallopian tube patency, with the advantages of non-invasiveness, no radiation, and no worry about the intravasation. And we found the diagnostic performance is comparable with SHG and laparoscopic. And also, hycosis is easily to control during the process, and we can avoid the artificial error as possible as we can. So another advantage of hycosis is it is more helpful for tuber assessment when patients with Mullering duct abnormal. So that's it. Thanks for your attention.
Thank you very much. So because this was a pre-recorded presentation, we will not have any questions.